I'm Michael Brant-Zawadzki. I'm the Senior Physician Executive at Hoag Hospital and oversee the Pickup Family Neurosciences Institute. I have two guests with me today to talk about a topic that's misunderstood by the general population. So we have two experts to help clarify some of the misconceptions, some of the stigma around seizures. And just to introduce the topic, we know of some very famous folks who have been afflicted with this disorder. We know famous authors like Fyodor Dostoevsky was an epileptic, Teddy Roosevelt, one of our Mount Rushmore presidents, and two of my favorite rock stars, Prince and Neil Young, also suffer with epilepsy. With us today to discuss this unusual, maybe not so unusual syndrome is Dr. David Millett. Dave is the Director of Neurology Services at the Pickup Family Neurosciences Institute and also heads up our epilepsy program. He's a subspecialty trained epileptologist and will talk to us about his perspective on it. And also Vivek Mehta, Dr. Mehta is a neurosurgeon and is the Chief of Service of our epilepsy services under the program that Dave heads. So Dave, let me start with you. Lots of folks have weird episodes that are seizure-like. They pass out, they may shake. What's the difference between a seizure and the condition that we call epilepsy?
A seizure is a single discrete event. It's a change in the behavior, the mentation, level of awareness of the patient that corresponds to a change in the electrical activity of the brain. So it's either a motor, sensory, cognitive change, and we can often see changes in the electrical activity of the brain that coincides with that.
So lots of things can cause dysfunctional electrical activity in the brain, whether it's drugs, whether it's a sudden infection, for instance, inflammation, even in some folks, lack of blood supply for a transient period of time. People wake up and are shaking. Is that epilepsy?
So it might be epilepsy. Your first question was, what's the difference between a seizure and epilepsy? So a seizure, as I mentioned, is a change in behavior with a correlative change in electrical activity. Epilepsy is an enduring condition of the brain where an individual is predisposed to having subsequent events, subsequent seizures. With regards to the other episodes that you mentioned, shaking, bizarre feelings in the stomach, overwhelming feeling of déjà vu, feeling like you're walking around in a dream in the middle of the day, those could be seizures. Sometimes they are, sometimes they're not. It requires some diagnostic testing to unpack that.
So when my wife accuses me of having absence seizures because I'm not paying attention to her and staring off into space, she may be right about my behavior being absent, but it's not necessarily an absence seizure. Tell us what absence seizures are. So
your wife's I'm not sure if she's right or not. I don't want to get you into trouble. But so absence seizures, unfortunately, it's a term that is overused today. It is a term that refers to a pediatric, a childhood form of seizure and a childhood form of epilepsy. So one of the most common childhood forms of epilepsy is childhood absence epilepsy. They usually begin at 5 or 6, and they're typically manifest by very brief staring episodes, the absences. Those seizures, those absences last about 10, 12, 15 seconds. It's almost like lights off, lights back on again. There's really no after effects from those seizures. And by 9 or 10 years of age, those seizures are gone.
Epilepsy can also be a disabling, even a lethal condition. Vic, you recently told me about a family you befriended whose son actually died, actually a notable actor. Cameron Boyce Foundation was named after him, who actually died from epilepsy. Tell us how that can happen, what happened in his particular case.
Yeah, so SUDEP, which is sudden unexplained death in epilepsy, is one of the most tragic consequences of seizures that may be poorly controlled. It's rare, but it is the leading cause of death in people with epilepsy. We established a relationship with the foundation through personal contacts and are hoping to raise awareness about the condition of epilepsy in general, what you should do when you're first diagnosed with a seizure, what are the signs of seizures, how to get referred to a tertiary level 4 epilepsy center where you have experts like Dr. Millett, fellowship-trained epileptologists with expertise in that area. And our goal with this partnership is to raise awareness about getting proper care and avoiding the fatal consequence of SUDEP.
So Dave, Vic raises a very interesting and important point. One of the problems is lack of awareness, not just in the general community, parents, kids, but by our colleagues, physicians who really don't know the manifestations of epilepsy sometimes. They miss the diagnosis, unfortunately. That can happen without having the kind of specialty that you have. So we're very fortunate to have a level 4 center here at Hoag in the Pickup Family Neurosciences Institute. It's the highest accreditation that an epilepsy team can get from the National Accrediting Agency.
A level 4 center has to provide all of the diagnostic and treatment modalities for a patient who has epilepsy. So that at minimum, that begins with the neurologists, the epilepsy specialists that are capable of making the diagnosis and the tools necessary to make that diagnosis. So that includes special MRIs and radiologists that have expertise in understanding what brain structures look like, the anomalies or the malformations that might lead to seizures. It also requires the ability to perform EEGs, both in the outpatient setting and in the inpatient setting.
EEGs are the electroencephalograms that measure brain waves
the
to look for
brainwave
those
tests,
distorted, dysfunctional, non-rhythmic electrical activity.
There's a very comprehensive list of tools and personnel resources that a level 4 comprehensive epilepsy center has to.
Including expert neurosurgeons like our friend Vic.
Including expert neurosurgeons.
How do you approach the medication management, and when do we look for more invasive neurosurgical approaches to epilepsy?
So it's individualized, and there are some patients who we might quite early in the course of their disease think about something beyond medications. In general, medications are the first line therapy for anybody who's diagnosed with epilepsy. At that point in time, after 2 well-chosen and tolerated anti-seizure medications, if that patient is still having seizures, they are at risk for significant problems down the road, drug-resistant epilepsy. So accidents, falls, traumatic brain injury, burns, SUDEP, sudden unexpected death, all kinds of problems, work-related, family-related, driving. So we really want to get those patients assessed for something else. And the something else is oftentimes surgery, which again is somewhat misunderstood, and I'm going to let Dr. Mehta.
Yeah, Vic, so we have much more advanced, precise techniques that we've developed over the last 5 years. Tell our audience about that.
I'd love to talk about that. So epilepsy surgery has been around for decades, and it's one of the few surgical procedures where a randomized clinical trial has been proven to be effective, safe, and many patients can be cured of their seizures. Over the last 5 years, we've seen an emergence of technology to help make surgery safer, less invasive. Things like laser ablation, neuromodulation, deep brain stimulation. These techniques are much more gentle. They help patients get home faster, with less side effects, less pain. And many of these techniques can be as effective as the larger open surgeries where people stay in the hospital for days. So a really exciting time to be in the field of epilepsy, And we're seeing really promising results with minimally invasive techniques.
Yeah, one of the more impressive things I've seen you do is under imaging guidance, under MRI scan, you can make a little keyhole in the skull and guide a probe to the area that Dave has identified as the source of the electrical storm that sets off a seizure throughout the brain. That's very impressive. We weren't able to do that just a few years ago, and now we can do that in a same-day surgery with the patient going home. Fantastic, but let's put this in a context. Dave, how many people actually suffer from epilepsy? And then take us through the percentages of those that suffer, how many become intractable, and how many end up going to surgery?
What we have seen recently is an increase in epilepsy, new diagnoses of epilepsy, or an increase in the incidence of epilepsy in older folks over the age of 50, 60, 70. We're seeing an increased risk of epilepsy due to strokes, brain tumors, concussion or repeated traumatic brain injuries, and some esoteric, some very bizarre causes, autoimmune causes of epilepsy that we're seeing emerge in older populations. But with regards to the broader question of how common is it and how easy is it to control with medications, about 1 in 26 individuals will be diagnosed with epilepsy.
Wait a minute, 1 in 26?
1 in 26.
So when we're sitting in our meeting in the conference room with 100 people, about four people there will have epilepsy.
4 people over the course of their lives will be diagnosed with epilepsy. If they
Wow.
don't have it already, they will likely develop it at some point in time.
I just want to get these numbers, again, solidified in my brain. 1,000 people, 1 in 25, do the math for me.
So of those 40 people, let's say in a population of 1,000, about half of them will be well controlled with the first medication that you give them. And it almost doesn't matter what medication it is. About 12 or 15% will be well controlled with the second medication. But medication becomes a law of diminishing returns. And once you've tried 2 or 3 or 4 medications, it's very unlikely you're going to find a combination of anti-seizure medications that's going to provide complete seizure control. And it's for that population, about 1/3 of all patients with focal epilepsy, that we then think about surgery.
Okay. And for that, you really need advanced surgical techniques, tools, and hopefully minimally invasive expertise with the latest image guidance that we can provide at Hoag. Any guidance to our audience? When should they seek a diagnosis? If I'm straining at the gym trying to lift 200 pounds, and this happened to me actually. The guy next to me at the gym was doing exactly that, and he suddenly falls down and has a full-blown seizure. Does that person need to come to you?
So that's a good question. That person in that provoked scenario probably doesn't need to come to me, but due to the reality of the society that we live in, that gym will have called the paramedics. That patient will end up in an emergency room. His driver's license will be suspended, and he will have to see me in order to get his life back on track again.
You just foresaw what exactly the scenario that happened with this guy. The good news is I saw him at the gym 3 weeks later, and he happened to have a little arrhythmia in his heart. So his heart's electrical rhythm got disturbed. That led to insufficient amount of blood flow to his brain, which led to his electrical system in his brain going awry. That was his seizure. He does not have epilepsy. But a very good point is that it's important to be able to differentiate those that go on the pathway that we can provide at a level 4 center. I want to get back to SUDEC as a closing point of discussion. Can we prevent sudden death from epilepsy in those that have epilepsy? Is that a preventable event?
So the technology is advancing rapidly. We're able to implant devices in the brain that help detect where the seizures are coming from for patients who rarely have seizures, but those seizures may be very disabling. There are wearable technologies that are emerging, and we're helping to develop some of the technology in that area. But yes, the hope is that through the research and the technology that we're partnering with, we'll be able to prevent this.
And Dave, one last question for you, because I'm sure there's some people in the audience that have heard about Charlotte's Web and THC and marijuana's in the news in and around seizures. What's the scoop on that? Is there a hope with THC, or is it hype? And also talk to us about dietary issues, because I know that there's an interplay.
Yep. So another half hour. There's CBD and there's THC. CBD has been actually proven to have anti-seizure properties, and there is an FDA-approved and regulated medication that we can prescribe for some patients who have epilepsy. That is, it's not pure CBD, but it's as pure a CBD as can be cultivated from the cannabis plant. So we do know that CBD is an anti-seizure medication, and we use it as such. THC, the jury is out. There are some patients who clearly seem to have seizures associated with THC use. I have patients who tell me I can't smoke marijuana because I know it will give me a seizure. There's animal data to suggest that THC can lower seizure threshold and increase the risk of having seizure.
As far as diet is concerned, Dave, I remember you telling me about a patient that still sticks with me, one who had sudden death with an epilepsy condition because she reverted back from her sugar-free diet, went to a party, birthday party, cake, sugar, and suffered terrible consequences. What's the connection between sugar and epilepsy?
So we've known since the 1930s that there's certain dietary interventions that can reduce seizures. Back then, the two observations that were made was that prolonged periods of fasting, so fasting for several days on end, could reduce seizure frequency in patients with epilepsy living in colonies. There were epilepsy colonies at the time. And the other finding was that what's referred to as a ketogenic diet, that is a diet that is very, very high in fats, and in protein, but very, very low in carbohydrates of all kinds, also has a protective effect in terms of preventing seizures. So it's only a cure for about 10 to 15% of folks, but it's essentially equivalent to pulling out my prescription pad and writing a prescription for their second or third medication.
But you don't tell your kids, don't eat those sweets, you're going to have a seizure, do you?
No.
Okay, just checking.
So epilepsy is complicated. There are structural activity, or there are structural issues in the brain. There's connections in the brain. There's electrical activity. Piecing all that together takes a team from neuroradiology, neurology, our neuropsychiatrists and psychologists, and then the surgeon. Each member looks at the condition through their own lens, and we synthesize an appropriate treatment plan. So these disorders are complex, the treatments are complex, but we make them safe and effective through teamwork.
Yeah, I'm glad you mentioned that. You can't discount the importance of our affiliated caregivers in nutrition, as we just heard about sugar, our psychological support systems for these patients, because these patients do have significant socio-psychological issues that can be a major component of their disability. So having this team and having the two of you on it makes us feel like we really provide that number of 1 in 24 in our community having seizures, having the epilepsy program at the Pickup Family Neurosciences Institute be so robust and led by the two of you is a great privilege. Thank you. Thanks a lot for being with us.
Thanks for having us.
Thanks, BZ.